am I correct? So patients are having like EKG changes, and they need to have their potassium lowered. They're needing fluids, they're having hyponatremia or hypernatremia and needing to have that evaluated. And those are all kind of emergency situations. So we are moving away from the emergency situations and more into the chronic kidney disease. So the chronic kidney disease, CKD, is what we'll be talking about for most of the next 2 weeks. We do have one section next week of acute kidney injury that we'll be talking about. But for the most part, we're going to talk about chronic kidney disease. And for the most of this next section, you're stuck with me. So we'll start out. I have some pictures here. We've not been traveling. We've been busy enjoying our mortgage here in South Carolina, and Thomas doesn't have a fall break this year. So these are from last year. And like I said, I've been sick for the last week, so I didn't have time to update. But we went to Yellowstone last year for his fall break, and it was one of the best trips that I have ever been on. If you've never been, I highly recommend. So this is one of the um, pools there that have the sulfuric acid coming out, and they make the ground very brittle and not safe to walk on. So pretty cool. We went.
Was that an October visit?
It was in October last year. It was the middle of October last year. It was the last week that the park was open with amenities. Thomas was really upset that his aunt gave him pink snow pants because blue is his favorite color, but they're hand-me-downs because like we didn't really need snow pants in Colorado or in South Carolina. But my sister gave us them to use for when we go back to Michigan. So he's like, doesn't Aunt Ashley know that my favorite color is blue? I'm like, buddy, she didn't buy them for you. They were Addison's before they were yours. So, but he managed. But it was awesome. It was like cold in the morning in October, but very nice in the afternoon. And there was hardly any people there. So mid-October is a great time to visit Yellowstone. Otherwise, you could be stuck in traffic there a lot. Um, so highly recommend if you get a chance to go. So moving on to chronic kidney disease. These are the objectives. There are a lot of objectives here for chronic kidney disease. Um, Pay attention to these when you're studying for your exam, along with the um, uh, practice questions that we have, and then the things that I highlight in the slides. One of the complaints I get about this section of my teaching is that like the practice questions don't necessarily, the students don't feel that they align with the exam questions. They do align with the exam questions. The exam questions are just harder because I'm asking you to combine all the concepts. When we're doing practice questions, we are doing practice questions on one concept. And on the exam questions, I'm asking you to figure out what the issue is and what needs to be done. I'm not telling you like, oh, we just got done talking about hyperkalemia, so this is a hyperkalemia question. It's like, here's a patient with CKD, here's their labs, what's going on? So I think this is harder because everything is than some of the other things that I teach because everything here is so intertwined where previously like in GI and self-care, everything was kind of by itself. And so I think students feel that this section is trickier than other topics that I um, teach. So one of the things we're going to practice on the case day, and if I can recover a practice thing is put or a practice assessment that I had put together is putting all the concepts together. All right, so we're learning about all of these things individually, but you need to look at them as a whole, and how do they interact, and how do I evaluate a patient who has CKD. All right, so talking about definitions and staging of CKD, chronic kidney disease, we have two research groups and guidelines. We have the National Kidney Foundation, um, and we have the Kadogi guidelines. The NAPLEX book and most places follow the Kadogi, but some people like Nephrologist may follow the Kadoki. All the things that I am going to talk about, excuse me, that are guideline related are from the Kadogi guidelines. All right. But one of the, NAPLEX likes to have questions about which guidelines are used for this disease state. This makes it a little bit easy because kidneys, right? So keeping that in mind. So when we're talking about kidney disease is a general term for a bunch of disorders affecting the structure and the function of the kidney. Kidney, excuse me. Kidney disease is just a big umbrella term that is a catch-all for all these terms here, right? So we have acute kidney disease, AKI, which we are going to discuss next week, and that is the rapid loss of kidney function over days to weeks. All right. And AKI can happen if you have normal kidney function, and it can happen if you have CKD. So you can have CKD and still end up with AKI. And so keep that in mind that a patient can have CKD and still develop AKI or acute kidney disease, and that can make their CKD worse. Also, acute kidney disease or acute kidney injury, if it's not treated right away, that can lead to CKD, chronic kidney disease. And so that's why it's really important for us to identify patients who have acute kidney injury and get them treated right away so that we are not killing those nephrons and leading to CKD on your acute care rotation, or if you work in the hospital are related to an internal medicine floor, you probably see a lot of acute kidney injury on that rotation and in the hospital for that section. It's one of the most common things that I saw working inpatient, and I had to help manage that. Right. But this week we're going to focus, and the beginning of next week, we're going to focus on chronic kidney disease. Okay. And chronic kidney disease is multiple processes. There's different ways that we get chronic disease that lead to progressive, and it's often irreversible loss of kidney function over several months to years. So chronic kidney disease is often irreversible, which is very unfortunate. Right, it's progressive, so it's very similar to like COPD. You learn is a progressive disease, right? Chronic kidney disease is a progressive
Makes
disease. It
sense.
like doesn't get better; it only
And
continues to get
ang
worse, and we
besar
can
ni na
slow down
so malo
how
sin
fast
sanya
it
ba
gets
ti mana
worse,
wali
but
wala
we
sin
can never
doctor
really
sin
make it get
namin
better.
ya pang
Okay,
besar sa to mga ba pero
end
bishes.
stage renal disease is when the patient has total or permanent kidney failure, so their kidneys are no longer working. All right, so end stage renal disease, they are on dialysis. And so if a patient is on dialysis, they meet end stage renal disease. I have a question about when transplant is indicated. So transplant is often like I'm not a super expert on transplant. Maybe Dr. Gonzalez might have more insight to that just based on how he's practiced. But if a patient has end stage renal disease and we think that they have and they're on dialysis, we think that, and then we think that they have longevity in their life. We like if they're a young patient and they're healthy, we might try to get them on dialysis. I know patients who have like lupus end up getting a kidney transplant often before they end up on dialysis. I'm not really sure what the criteria is for that question, and that kind of goes beyond the scope of our topic here. Dr. Gonzalez might talk about it a little bit more when he talks about dialysis itself. So that would be a good question to bring to him before that dialysis lecture. All right, so let's review the GFR. I feel like you've probably talked about creatinine clearance and GFR with Dr. Gonzalez the last 2 weeks, yes? Okay, great. So that should be a review. So GFR is the glomerular filtration rate, and this is equal to the GFR of one single nephron times however many nephrons a patient has. So in this picture, you can see two separate nephrons here. And we see the glomerulus, all right, along with the tubule. And then they go into the collecting duct. All right. And the same thing over on the right. There's the glomerulus and the tubule, and they go into the collecting duct, and we have the loops and into the collecting duct. All right. So the amount of blood that this nephron or glomerulus is able to filter is the single GFR for that nephron. Then we multiply that by all the nephrons that the patient has, and that's how we get their overall GFR. Well, like, how are we going to do that? We're not going to go count nephrons. That would take a lot of time, energy, not very efficient. And so we estimate how many nephrons a patient has based on their age, their sex, their body size, and we use that to calculate how many nephrons they have and what their overall GFR is. There's several different ways to calculate the GFR. One of the ways you might have is the Cockcroft-Gault, which is the creatinine clearance. That's what we're most familiar with. You probably were introduced to that P1 year. And that's because most of our drugs are dosed based on the creatinine clearance or the Cockcroft-Gault equation. So this one is specifically for drug dosing most of the time, and this is our creatinine clearance. And you should have that equation memorized. I think you probably had some questions on that for the first exam here, and it's going to be one of the calculations that you're going to have to do over and over again. Right, and so that's generally our go-to. We also have other ways to calculate the GFR. We have the gel life, the Salazar, the MDRD, and the CKD epi. When we talk about GFR and grading CKD, so how bad is a patient's CKD, we're going to use the MDRD equation or the CKD epi. And most of the time, when we're calculating it, I'll see people use the CKD epi. Sometimes on like EHRs, it's calculated, and I will see like the MDRD, like this GFR was calculated by the MDRD. So both of them are acceptable as far as staging our CKD. So how bad are the CKD? Is the patient's CKD? So just a reminder, we have like the creatinine clearance versus the GFR. The creatinine clearance, you should be very familiar with this calculation. You should have it memorized. And because we are using this as far as the weight here, if we use the actual body weight, if they're underweight, we use the ideal body weight if they're normal weight, and if they're overweight based on their BMI, we use the adjusted body weight. So that's the weight that we use. This creatinine clearance tells us if medications are contraindicated or if they're renally dosed based on that creatinine clearance level. The GFR, we don't commonly calculate this, but it can be reported with a BMP. So we'll get the BMP and it'll be reported in the EHR with the BMP. And again, it's used for assessing the staging of kidney disease. So how bad is their kidney disease, and for dosing select drugs. So we do see some drugs like metformin and SGLT2 inhibitors that are dosed based on GFR. So we are seeing more drugs dosed based on GFR than we used to historically. So be mindful of that. And you should be aware that metformin and SGLT2 inhibitors are dosed based on GFR and not creatinine clearance. So again, the Kadogi recommends using the MDRD or the CKD epi 2021 to calculate the GFR. I don't want you to memorize the equation because, again, that's something that's reported in the EHR, and that's something that I would use an online calculator for. But I do expect you to know what goes into the equation for the CKD epi, and that is serum creatinine, age, and sex. You'll notice that it was just in 2021 that they removed race from the CKD epi equation, and that's a good thing, right? Right? If you want to read more about that, why race was removed, this is linked to an article to describe that, but having race in the GFR equation is one of the ways that systemic racism shows up. And so there was this theory that people of color, African Americans, had higher muscle tone. So we needed to put a race factor in that. And so into the equation because that affected how many nephrons they had. And what happened with the race in this calculator is that we were overestimating people of color's renal function. So they were getting care later on in their CKD, and they were ending up on dialysis more than white people. All right, so we were harming people by having this race factor in here because it was based on an assumption that Black people are more muscular and that we need to have that in there. And we actually overestimated Black people's um, uh, creatinine clearance or GFR, and that has led to a huge disparity in CKD in people of color.
No, but as you're finished, you can.
This is why we be
Well,
careful. We're very careful when we see
I'm
anything
not
that is a
sure. Because
race-based
when
recommendation.
that was
Like
like,
how is
when in
this
case your dad
being,
replica,
how is this determined?
just
Because
take
race is a
2
social construct. It's
and
not
leave
a
2 for
biological
tomorrow to
construct.
your soil.
So you should be
So
very careful
it's
about
not
how
kí
you
wá ṣe wàhálà.
interpret
Wọ́n
anything
fẹ́
that
jẹ
is a
lọ́sàn-án.
race-based
So wọ́n fi
recommendation.
mẹ́rin sílẹ̀ náà máa jẹ lọ́sàn-án yìí. Wọ́n jẹ kìíní ìkókó
All right,
láàárọ̀.
so how do we define chronic kidney disease? So we define it by having abnormalities of the kidney structure or
I
function.
get it about finish
So the
everything.
structure is how the kidneys appear, what is going on inside the kidneys, or the function. So how well are they doing filtering the blood? How well are they doing filtering the protein and not letting protein out into the urine? So structure is exactly that. How are they built? What is going on? Like what is the infrastructure, the architecture in the kidney? Function is how are they filtering the blood? How are they filtering the protein? And so you have to have an abnormality for more than 3 months. And that is key for you to have the diagnosis of CKD. So markers of kidney damage include albuminuria, which is what we're going to talk about most today. And that's the AER, albumin. I cannot remember what E stands for right now. I'm sorry. Or the ACR, albumin to creatinine ratio, and greater than 30. So if you have more than 30 of albumin in your urine, you have albuminuria. If you have that for 3 months, you have CKD. If you have urine sediment abnormalities, if you are having electrolyte disturbances, those can all indicate that you have CKD, but albuminuria is going to be one of the easiest things to determine the function, right? So this would be a function issue. And anything that is a structure issue, says pathological abnormalities detected by histology. So this is like looking at the cells under the microscope. So what's wrong with the cells? And this is structural abnormalities detected by imaging. So this would be like a ultrasound showing, like for me, I have a right pelvic kidney. It's smaller than my left kidney. And so, or you have swollen kidneys. So these would show up on a microscope or x-rays or ultrasound or a CAT scan, and these would be structure issues, right? And if you had a kidney transplantation, you obviously have CKD because you no longer have your own kidneys. So you can have one of these markers of damage for, again, greater than 3 months. So if somebody is born with a right pelvic kidney that's smaller than their left, and they are greater than 3 months old, that is chronic kidney disease. If you have albuminuria one time, that's not chronic kidney disease. It's if that albuminuria is still there in 3 months that you have chronic kidney disease. Or, right, this is not an and, this is an or, your GFR is less than 60 for 3 months. Again, this 3 months is with the markers of kidney damage and the GFR. Thanks, Jose Avan, for the assist. I appreciate you. So AER is albumin excretion ratio. Are there any questions on this? Because one of the exam questions will be, here are these patients. This is what they have going on. This is their GFR. This is their ACR. This is their imaging. Which of these ones, this is how long they've had these issues. Which one of these has chronic kidney disease? So make sure you are able to apply this and tease these out of a patient case. So just to expand a little bit longer or a little bit more on these markers of kidney damage, albuminuria is the most common, most frequently assessed marker of kidney damage. This reflects how much glomerular permeability we have with those large molecules. Albumin is protein. It is a large molecule. It should not be going through our filter. So if we're pushing that through our filter, that we're pushing really hard, and that's not a good thing. Okay. We typically use the ACR to assess this. If the ACR is greater than 30, that indicates an increased risk of all-cause mortality and cardiovascular mortality. So greater than 30 is like, hey, you are at increased risk of having a heart attack or a stroke, or you're at risk of dying because there is something going on that your kidneys aren't working and they're pushing that protein through. Urine sediment will be things like red or white blood cell casts. And a lot of that, like the red and white blood cells or the cast cells, indicate that there is some glomerular injury going on, or there's inflammation going on. So the injury or inflammation is going on. Again, these image abnormalities are going to be things like polycystic kidneys. So the kidneys have a bunch of cysts in them, hydronephrosis, echogenic kidneys. Those would all be things that say that your kidneys are not normal shaped. All right. And then pathological abnormalities come from a biopsy. You'll be looking at the kidney under a microscope and you'll see glomerular sclerosis or interstitial fibrosis. All right, so testing your knowledge. All individuals with a GFR less than 60 milliliters per minute for greater than or equal to 3 months are classified having CKD, irrespective of the presence or absence of kidney damage. Great. A lot of answers coming in. And everybody is in agreement here. So everybody is saying true. Can somebody explain why this is true?
Listen. Se vai também, lo so. Qualche non mancare.
Is like structure functional abnormalities or GFR less than 60 for twins.
Okay. So we have a GFR less than 60 for greater than 3 months. That equals CKD.
Yeah, and I think you can have a perfusion based abnormality as opposed to an intrinsic base. So in the perfusion based abnormality, then it would not be a kidney damage. It would not be a damage of the kidneys. That's part of it, right?
So I'm sorry, can you say that again?
So when we say irrespective of the presence or absence of kidney damage, could it, is it hinting towards the fact that there is like perfusion issues as opposed as to intrinsically like nephron related issues?
Yeah, so, this one is, when it says irrespective of the presence or absence of kidney damage, we're talking about albuminuria showing up in in the blood or in the urine. Sorry, y'all. We're talking about protein showing up in the urine. We're talking about red blood cells, CAS showing up in the urine. So that would be the presence or absence of what appears to be kidney damage. But you're right, there is a perfusion issue here because we are filtering less. So the GFR less than 60 does say that there's kidney damage going on, but not overtly. It says that they're filtering less. But the proteinuria or the red blood cells or the cast or the white blood cells in the urine would indicate that there is damage or injury to the kidney. But you don't have to have those if your GFR is less than 60.
I have a question, Dr. Hall.
Here.
What about patients? Because there are patients who are on medications like fooding medications that will increase the creatinine levels because they're on those medications. So the EGFR calculation will be lower due to that. But it's like a false, it's like a false value. We used to say that CKD.
So for patients who are taking extra creatine
There are medications that
or medications that increase, okay.
that block the secretion of creatinine. So eventually, our GFR will be less than 60, like continuously, because those patients are on those medications. For example, HIV medications like dolutegravir. But does that really mean they have CKD? Their GFR can be 50 throughout the time they're taking those medications.
That is something I'd have to look in closer because I'm not familiar with treating those patients. So I'd have to look into that closer, George. Okay. All individuals with prolonged structure kidney damage are classified as having CKD irrespective of their GFR, true or false? So this one, I think, is throwing people for a loop because it's not super clear. People are questioning what prolong means. So what would make this statement true? Yeah, so if prolong meant greater than or equal to 3 months, that would make this true. Great. Any questions about that?
So, didn't we need a second characteristic to fulfill the diagnostic requirement? Oh, equal to one or more. Oh, okay. Not, you don't need more. Okay, okay. Got it.
Yeah. Look, be careful when you're studying, because that equal to underneath the greater than or less than can get lost in the shuffle. So just pay close attention to that. All right. So classifying.
How
Yes.
since prolonged can also mean for more than 3 months. In a question like this, can we say it's true and false? False.
I'm sorry. What was that, Kingsley?
As I since prolonged can also be interpreted to be a period longer than 3 months. Can we then say for this question that is both true and false?
I'm sorry, I'm not understanding what you're asking because if
When
prolonged.
I interpreted prolonged, I interpreted prolonged to be something like in the last 6 months. That was my interpretation of the language, prolonged, something that is more than 6 months.
Yeah,
So
let's,
if I see a question like this, I would say it's true because my interpretation of prolonged will be more than 6 months.
right.
So can we say this answer is both true and false if we see a question like this in the exam?
Yeah, well, the exam will be much clearer, I promise, unless I'm still sick when I'm writing the questions.
Okay.
There will be no splitting hairs. It will be very clear whether it's been 3 months or not.
Okay.
All right. So the National Kidney Foundation lays out this classification. Did I take this slide out of your all? Do you have this slide in your deck? Yeah, okay. So we have different stages and for Kadoki, and they're 1 through 5. All right. And so here at 1 and 2, so people can have a higher GFR and still have CKD, and this is because they have a structural deficit. So they have proteinuria, they have hematuria, they have kidney damage, they have anatomic abnormalities. All right. So if I have proteinuria, I can still have a GFR of 80. If I have polycystic kidneys, I can still have a GFR of 70. And that's doesn't mean I don't have CKD. It means I have stage 1 or 2 because of whatever the proteinuria, the hematuria, the kidney damage. All right. Stage 3 is where we see that GFR less than 60. All right. So if somebody has CKD based on their GFR, it's going to be at least less than 60. All right. And stage 3 is where we need to start thinking about dosage adjustments for drugs. All right. So when you have a question that says patient, which patient do you need to be carefully reviewing their drugs for renal dosing? Is it a patient who has stage 1, stage 2, stage 3, chronic kidney disease? You're going to choose stage 3. That's when we're going to start looking really closely at their drug dosing based on their renal function. So this is Kadoki, not to be confused with Kadogi. And this is different, but it's similar. It's essentially very much the same. All right, so we have a GFR greater than 90. We have a GFR of 60 to 89. These align. But Kadoki was like, hey, there is too much difference between 45 to 59 and 30 to 44. Like people who have a GFR of 30 to 44 are worse off than people who have a GFR of 45 to 49. So we're going to break these out to 3A and 3B. But again, it's still stage 3 that we're going to worry about renal dosing. Right? The Kadogi also adds staging based on albuminuria. So if you have albuminuria, your GFR is 51, so your stage G3A, and your albumin urea is 102, you also are stage A2. All right. Because again, remember 30 is our cutoff because greater than 30 increases all-cause mortality and cardiovascular mortality. So A2 is 30 to 300 and greater than 300 is A3. So again, this is staging CKD. This is not indicating end-stage renal disease. If you are G5, that is likely end-stage renal disease because that is kidney failure. End-stage renal disease is an administrative term, and that is for reimbursement from Medicare and then in turn other insurances because commercial insurances typically follow Medicare. So end-stage renal disease includes patients who are being treated with dialysis, who've had a transplantation. no matter what their GFR level is. So end stage renal disease is again more administrative for reimbursement. People who have end stage renal disease are typically going to fall in G5, or if they've had a kidney transplant, they might fall higher. But again, ESRD is an administrative term. So why do we care about chronic kidney disease? We see this a lot in practice. We see this in our inpatients. We see this in our outpatients. We see this all over the place. And no matter where you're working, you're going to be dealing with patients who have chronic kidney disease. Unless maybe you go to peds. I don't know if anybody in here is interested in peds. I know Megan, who's graduating, is interested in peds, but we do have peds patients that have chronic kidney disease. But if you're dealing with the general adult population, you are going to see CKD. But 14% of patients in the US have CKD. Most of them don't even know. And if you're over 70, almost half of patients over 70 have CKD, because remember, age is part of the GFR calculation. So the older you get, your GFR goes down just by virtue of age. So if you're more than half of people over 70, or almost half of people over 70 have CKD. And that's why it's more common in people who are older. It is in 2021, it was the 10th cause of death, and it costs Medicare about $114 billion a year. It is highest in African Americans, Hispanic Americans, American Indians, and Asians. And again, disproportionately affects African Americans because of what we've done with the race factor in the GFR and access to healthcare. I thought I had a slide, but it must have I must have taken it out. Right. So how does CKD happen? So let's dig into the pathophysiology and how it develops. The first step is the initial insult. So this could be AKI. Somebody has acute kidney injury, and you can get loss of nephron mass. You get less nephrons or less nephron itself, which it decreases, right? And that leads to less function. So we have less nephron mass, less nephrons, we get less nephron function, right? Which leads to less perfusion pressure and a GFR decrease within the nephron, right? The kidney senses that it's getting less perfusion and less pressure, and it tries to compensate by activating the RAS, the renin-aldosterone angiotensin-aldosterone system. So we're going to try and compensate. We're going to try and pull ourselves out of that. And at first that works. We're going to get that pressure increase. That RAS is going to increase the pressure in the glomerular capillaries, and it's going to lead to increased filtration. So, and the RAS does this because RAS increases sodium and water retention to increase that pressure. More sodium, more water, more pressure, more filtration. Great, we've compensated. Everything's okay until it's not. I hope. So over time, our body, we can only compensate for so long. You just all got done learning about heart failure, right? Heart failure comes from you compensating from having a high blood pressure or having a fast heart rate. Your heart becomes overworked and becomes a big, huge muscle, and that you're compensating, but then it all goes when you get heart failure, right? Yes? Or have we already dumped that from our brains? Have we already dumped heart failure from our brains? Because we're on the kidneys. A little bit? Okay. So we compensate for a little bit, but then after a time, like months or years, the pressure in the glomerulus keeps building and keeps becoming increased. And so we get a hypertrophic glomerulus, which is similar to a hypertrophic heart, right? Left ventricular hypertrophy is okay. So the same thing is happening in our kidneys because that pressure is making our glomerulars work harder. It's a muscle, it becomes hypertrophic. Okay. then it becomes so used to working at that pressure, elevated pressure, that it keeps trying to compensate. And as it does it, more and more nephrons are no longer able to function from this increased pressure. So there's um, less functioning nephrons because they can't take the pressure anymore. They're working under such high pressure and they're just like, we can't do this anymore. We're out. And so we get a further decrease of the nephrons that are functioning. So we get a further decrease in GFR. Okay. And the permeability of the barrier is affected. So those little holes that we had there that could only get solutes through, so we could only get rid of our potassium, we could get rid of our calcium, those little holes start to get bigger and larger as the scar tissue builds up. So as scar tissue builds up, those holes are not able to maintain their small size for just letting solutes out. They get bigger. If the filter holes get bigger, what happens?
More,
I'm sorry, go ahead, Ernesto.
yeah. Things that shouldn't be filtered start to be filtered.
Yeah, you're absolutely right. So those things that should be filtered and stayed in start slipping through the holes, like that protein, those large molecules, that albumin. So protein and albumin are the same. Albumin, you end up with albuminuria passing through, or over protein in there. These could not pass through before all that pressure put that scar tissue and made those holes bigger. Right? So this is the process. We're having that increased pressure, those holes get bigger, we get albuminuria. Okay. So proteinuria can happen a lot of ways. It is kind of slow and steady increase in pressure over time that happens it, but that protein is toxic um, to the body, right? And so we start having that protein causing the production of inflammatory and vasoactive cytokines. And so all those markers, we start getting those cytokines, those and the inflammatory markers increasing, and this process just keeps going on over and over and again because we keep that proteinuria is causing those inflammatory markers and cytokines to keep assaulting the kidney essentially. And so that's why proteinuria is very dangerous because it continues to keep this process going to make the kidneys worse. And so if you have proteinuria, you will see a greater decline in your GFR than somebody who does not have proteinuria because that proteinuria is continuing to do the damage over time. All right, so here's the normal glomerulus, and this is one that has been damaged by the hyperfiltering of that protein. And so as you see, we are getting scar tissue. We're losing the flexibility over time here. We have scar tissue, we're not able to filter, our GFR decreases. We're not able to filter as much. With this scar tissue in here, we can't get as much blood through that nephron, right? All right. So this is a picture, again, describing what is happening in the kidney. We get that reduced number of nephrons. We get maladaptation, right? We activate that RAS, that renin-angiotensin, aldosterone and angiotensin system, that RAS activation, which helps you increase your holding on to water and salt, and that leads to systemic hypertension. So the kidneys and heart, for all of you that dump that heart information, I feel really bad for you because the kidneys and heart are closely related. Because that RAS is activated in the heart or in the kidneys, and that leads to hypertension. All right. All right, so we get that sodium and water retention, and we start getting a hemodynamic effect on the left. So we go through this hemodynamic effect. We get some vasoconstriction, things like that. And then we go over here to the other side with the normal hemodynamics, but either way, we end up at proteinuria. Each pathway leads, no matter which way we go from RAS, leads to proteinuria. Right? And then we start getting issues with the glomerular, we get that sclerosis, that scarring of the glomerulus, right? And we get progression of the and worsening of the GFR. Okay, so basically, our holes become super big. We start letting out stuff that we shouldn't in the kidneys. We start getting scar tissues we can't filter, and that protein, that albuminuria, keeps this process going, damaging the nephron, further decreasing the GFR. And so all this to say, all these slides and this really casual description is saying albuminuria increases the rate at which our CKD is going to progress. So if a patient has CKD, or has albuminuria, their CKD is going to get worse faster than somebody who doesn't have albuminuria. So what are the risk factors for CKD? Oh, there's a chart I was thinking of. So increased age increases our risk of CKD because our GFR is based on age. Decreased kidney mass. So if we have smaller kidneys, we don't have as many glomerular or nephrons, and our GFR is based on how many nephrons we have. Low birth weight, family history, race, and ethnic minority. So here we see the incidence of, and I tried to find an updated one, but this is the best one I could find last night. But this is the incident rate of end-stage renal disease by race. And we see this red is African Americans. It is significantly higher than any other race. And this is up to 2009. That is a huge jump. So do be mindful of that. Low income, education, systemic inflammation, and obesity are all risk factors for patients who are developing CKD.
And lower weight, I assume it would be because of that development, that there are some organs that take a little longer to develop.
I would have to look into that closer, Jose Bon. That's a good question. I don't know the answer to that. Now, there are some things that initiate CKD. So what's going to say, all right, I am pushing you to get CKD. Like, you have this, CKD is starting right now. Diabetes and hypertension start CKD. High blood sugar, uncontrolled blood sugar, your kidneys are constantly filtering your blood and trying to get that sugar out. If your blood sugar is high, your kidneys are having to work overtime to get that sugar out. And that is a lot of extra work, leading to hypertrophic. That sugar is toxic to the kidneys. So you're going to start seeing the initiation, the start of CKD, especially if your diabetes is uncontrolled. Hypertension, especially uncontrolled hypertension, doesn't just put pressure on your blood vessels, it's going to increase the pressure in your kidneys and the filtration. So if you have uncontrolled hypertension, you are putting undue pressure through the filtration on your kidneys. Right? So these are the most common causes of why CKD starts to happen. You can have glomerulonephritis, autoimmune diseases, infection, obstruction, drug toxicity, but most of the time, this process is started through diabetes and hypertension. What makes CKD get worse? Progress, right? Progression is get worse. So what makes CKD get worse? Hyperglycemia and hypertension. Right? So hyperglycemia, uncontrolled diabetes, uncontrolled hypertension. It is so important that for patients who have diabetes or high blood hypertension, that we are doing our best to control it, because that is going to start them having CKD. And if we do not control it, it's going to make it worse. Proteinuria, as we said, increases the all-cause mortality and cardiovascular mortality. And much like constantly filtering sugar, that protein is doing damage. Smoking causes damage. We talked about it causing damage to our blood vessels, increasing our risk of clots. It doesn't just cause damage to our lungs and our blood vessels, it also causes damage to our kidneys. And then obesity. Right, so when we look at patients who have end-stage renal disease and what caused it, 38% was caused by diabetes and 27% was caused by hypertension. Right, so please know that diabetes and hypertension can cause CKD and can worsen CKD. Because it's happening, what, 60% of the time, excuse me, end-stage renal disease is being caused by one of these two. Again, CKD and diabetes is an initiation and a progression factor for CKD. We have microvascular complications. It is highest in patients with type 1 diabetes because patients with type 1 diabetes are diagnosed younger than patients with type 2 diabetes, so they have a longer history of hyperglycemia. When we have that chronic hyperglycemia, we don't just have increased blood sugar, but we have other metabolic abnormalities. We start getting hemodynamic abnormalities and we start getting reactive oxygen. And so like we saw on the previous slide, diabetic nephropathy is the #1 cause of end-stage renal disease. Okay, we're going to stop here. We'll take a 5-minute break, come back at 2:37, and we'll talk about CKD and hypertension. All right. You will. Can you see my slides again? That's awesome. So let's talk about CKD and hypertension. This is, again, hypertension is an initiation, so it can cause CKD, and a progression factor, so it can make CKD worse. And this is because um, we're not really sure like what the cause is and what the effect, because these are so closely linked. So you should probably, it's kind of like the chicken or egg, what came first. So you should probably order CKD and hypertension on Amazon and see which one shows up first. And that'll be your answer. All right. Some of you are writing that down and some of you are getting that. But they're so closely linked that we're not sure if the CKD comes first and that leads to hypertension, or if hypertension happens first and then the CKD happens. So that's what I was talking about earlier about the heart and the kidneys being so closely together. All right. Usually we see them developing and happening at the same time. Most patients who have CKD have hypertension. Most patients who have hypertension end up with CKD. So they just go hand in hand. Right? And this is because the proteinuria, and which leads to the activation of RAS, which leads to increased water and sodium retention, which leads to increased pressure. All right. And so early treatment of hypertension is going to slow the progression of chronic kidney disease. That is very key. We want to make sure that we're treating hypertension. Again, this is, CKD is a risk factor for cardiovascular disease, but CKD and hypertension is also a risk factor. This is showing how intricately the heart and kidney are connected. All right. So if a patient has heart issues, you start out with heart issues, you're going to end up with kidney issues. If you start out with kidney issues, you're going to end up with heart issues. It doesn't matter. All right. So you can't forget everything you learned about the heart. Right. So patient is 72-year-old Chinese American female with history of polycystic kidneys, whose serum creatinine is 0.89 and ACR is 26 milligrams per gram. Calculate the GFR, and then does this person have CKD? If so, what stage? Because we're running a little bit behind, you're going to do this for tomorrow, and we'll talk about it tomorrow. All right. So what are signs and symptoms that a patient has CKD? It's going to be really hard to tell. People, again, almost 50% of people over 70 are walking around with CKD and don't even know it. We do have signs and symptoms, but those don't happen until later on when the CKD is pretty bad, right? So very often patients with CKD are living their normal lives and not aware of anything that is going on in their kidneys. Patients of all different backgrounds can develop CKD. So do be mindful of that. So signs and symptoms, again, in that stage 1 to 3, they're not going to have any signs or symptoms. It's when they get to that stage 4 that the signs and symptoms are going to show up. And they're going to end up with things like edema, shortness of breath, cold intolerance, palpitations, muscle cramping and pain, depression, anxiety, fatigue, sexual dysfunction, right? And then we will also see things like increased blood pressure, left ventricular hypertrophy, arrhythmias, dyslipidemia. We'll see some GERD, potentially weight loss, foamy urine. We could see a secondary hyperparathyroidism, which we're going to talk about next week.